People all over the world are united by a shared aspiration to live a healthy life. Helping people to live healthier and longer is the reason we exist. At Siemens Healthineers, we pioneer breakthroughs in healthcare for everyone, everywhere. The world needs groundbreaking innovations to fight the most threatening diseases like heart disease, stroke, and cancer. Where time is of the essence, our solutions allow for faster diagnoses and decision-making. Our novel photon counting technology is the beginning of a new era in imaging, providing previously unseen levels of crystal clear detail. Where precision takes priority, we provide the latest in robotic and image-guided therapy. And together with Varian, we are taking a leap in innovative cancer care. With more data comes more opportunity. Our digital and AI solutions enable clinical professionals to work more efficiently so they have more time for their patients. And digital twins have the potential to transform the healthcare of tomorrow, paving the way for personalized and preventive medicine. People are at the center of everything we do. We are a team of 66,000 at Siemens Healthineers, passionately pushing the boundaries of what is possible, proudly serving our customers by constantly bringing breakthrough innovations to market, enabling healthcare professionals to deliver high-quality care and ultimately improving patient outcomes and lives. The most advanced technology is only as good as the number of people who have access to it. As innovation leaders, we are committed to delivering scalable solutions that can be tailored to the needs of healthcare providers and local infrastructures across the world. We are pioneering breakthroughs in healthcare for everyone, everywhere.
Today we have the honor of having Professor Suhny Abbara lecturing us today about the cardiac CT past, present, and future. The initial suggested title was, are the 2021 chest pain guidelines worth to read? But during our time here, he said, that's a little bit too simple, so let's make it a little bit more complex. And what he's going to do is he's going to give us an overview of what he and others have contributed to the field of cardiovascular imaging. Suhny is currently, as you can see on the screen, Professor of Radiology and Chief of the Cardiothoracic Imaging Division at the UT Southwestern Medical Center, one of the most important medical centers not only in the US but also in the world. Suhny has authored more than 350 papers, 6 textbooks of cardiovascular imaging, is the current editor for Radiology Cardiovascular Imaging, past president of the Society of Computed Cardiac Tomography. But I would say that more so than his brilliant career in the field of radiology and cardiac imaging, he's one of the most brilliant human beings I've ever met. Sitting with him in the reading room was always a challenge. He has, as my friend Carlos Rojas used to say, a different chip. I never seen eyes as fast and as illustrious as Suhny. And it was an honor to be sitting with him for 2 years and call him my attending. Suhny, it's an honor and a privilege for the Department of Cardiology, for the Department of Radiology, and for our cardiovascular imaging division here to have you. Thanks for your time. I know coming to Bogota is not easy. We're taking time from your family and from work. But I can't think of anyone better in the world to come and teach us about cardiac CT, which it's your passion. I can tell you we're ecstatic to have you here. Thank you again for joining us, and it's really an honor and a privilege. Thank you.
Thank you, Hector. Okay, thank you very much, Hector, Dr. Medina. I have to say I've been really impressed with what I've seen here. You have a fantastic non-invasive imaging department and a great number of great leaders in imaging. And it is my honor to be here and at 2,600 meters above sea level, my highest honor in my career, to share some thoughts with you. So, I figured I will go back in history a little bit with all of you to see where we came from and why we are where we're at now today. So I'll show you a bunch of firsts and things that happened in cardiac CT. And it all started here. It started actually where I was born in Hamburg, Germany, when these guys, these are obviously the Beatles, were doing gigs in Hamburg before they were really known. People in Germany already saw the future, right, and loved them. And this, of course, is their 7th album, I believe, called Abbey Road. And these are the Beatles crossing Abbey Road. This is Abbey Road. And in Abbey Road, the studio is on this side. So they got a little lazy, right, for the cover. And there's a window there where a guy, so they made so much money for the company called Electrical Musical Industries that they hired a full-time inventor. And that guy is this person. This is the window. You look out that window, you can see the Beatles cross the street. I made that up. I don't know where that window goes. But of course, this is an employee of EMI, and that is Sir Godfrey Hounsfield, who put together the first magnet. And of course, he used information that his peers and people before him have developed. One guy in particular is Alan Cormack. And Alan Cormack was in the US, in Boston, in the Harvard Hospital, and later at Tufts, where he did the mathematical foundations for the filtered back projection that we are using today still. So that's why these two guys got the Nobel Prize for what they did. And look, in 71, the first scanner was assembled. And 2 years later, you could buy your first cardiac CT scanner from a record label. How cool is that? And if I talk to older radiologists in the US, they can remember having had one of those Emmy scanner, is what they call it, from the record company. Okay, and then there is this guy who was honored at the NASCI last year. His name is Louis Wexler. And I think it is very much underappreciated that he and his team were kind of ahead of the times. In 1977, they would be using a CT scan, very slow, old, crappy machine, sorry, not very good machine back then, but they were binning the data based on the EKG, which they simultaneously recorded by hand afterwards. Took 2 days to come to the images. And they binned them in, let's see, I think I have some data. Here's that paper, just a page worth of paper. It took 6 seconds for one rotation. So you can imagine the image quality is not what we see today. And they scanned twice to cover the heart. And in between this, so 18 seconds to cover the heart. And they have these 7 segments that they binned, and they called it stop action CT. In 1977, imagine that. So these are the images they were getting, and you would say, that's terrible, we see much better images today, but seeing motion-free images basically of the heart was unheard of then, actually unheard of for 10, 20 years to come afterwards. Okay, so really cool. This is how the machines looked, different fashion back then. And you know, I remember using a computer like this where the keyboard is inside of the same thing. So kind of cool. And then there was something else going on, which is also very cool. This is at the Mayo Clinic in Rochester, Minnesota, where they built this machine called a dynamic spatial reconstructor. It would span 2 floors, 1 floor and then 1 below. And it had 14 X-ray tubes, and generators on a gantry that took 3 seconds to rotate around the patients. They told me that when they turned the machine on, the lights went dark in the whole hospital wing because it drew so much power. And they were able to get this. This is in 1980, a coronary CT angiogram, long before most of us realized you can do this. And even better, if you have 2 days, oh my goodness, it's not playing. Let me do this. Just going back and forth. This looks like a beating heart. This is a 3-chamber view. Left atrium, left ventricle, LVOT, and the RVOT and the aorta. That was in 1980, a 4-dimensional CT ventriculogram. So of course, needless to say, because the machine is ginormous, and this is the guy standing there. That's the floor below them. You needed 2 floors, many $1 million. this was a dead end. So this didn't get developed any further. But today we're like dual source. That's great. Two X-ray tubes. They had 14. Okay, but it all helped us get where we're at. Then calcium scoring happens. So there's this is the first paper authored by Arthur Agatston, a cardiologist, and Warren Janowitz, his colleague, a radiologist. They worked together. By the way, I'm going to show you a text in a moment. So they basically used electron beam CT, which I'm showing you here, where you have an X-ray beam, electron beam, going through a vacuum, through deflection coils, and then the electron beam hits a fixed ring of anodes that then emit radiation from there. So no X-ray tube. This is just all in a vacuum. Super fast temporal resolution. And of course, we basically then look for the motion-free areas of high attenuation. Are they above 130? Is it more than 1 pixel? Then you would count them, and you would multiply them if they are in a certain range with a cofactor to get the Agatston method. Today, I would argue it is not the most exact method because of this stair-step function, but it's one of the biggest successes in medicine. And let me just show you this tweet I saw from Juan Buttle in Miami at Baptist Hart. The initial tweet from Dr. Mathis says that when they submitted their work on coronary calcium, the AHA rejected their abstract in 1981. So if you got an abstract rejected from AHA, maybe you are way ahead of your field and they are not getting it. So don't feel bad. Keep trying. You might be ahead of your field, just like they are. And look at that. Who's the first author of that abstract? Warren Janowitz. Very proud of my Warren Janowitz, who's the first author on the abstract. And you know, had they done the same in the paper, now it would be the Janowitz score and not the Agatston score. So yeah. So small things can have lasting effects. So pretty cool. Don't get discouraged if you get something rejected. You're probably ahead of the game. Then the first publication, New England Journal of Medicine, 1998, on electron beam CTA was by Stefan Achenbach and his group. He was a trainee at the time, showing a surface rendered, not volume rendered, what we see today, a surface rendered imaging of the left main LED and the cutoff here of the circumflex, looking just like in the cath. So that was using electron beam CT. So why are we not using more electron beam CT today? We get awesome images that look just like the images today, where mechanical CT doesn't give it to you. Well, the issue is the slices couldn't get any thinner than 2.5 millimeters. It was just not possible with the anode rings that they had. So it has also become a dead end. But fortunately, soon thereafter, so until then we used cables to connect the gantries. So you couldn't spin continuously. You had to spin once or so, or 1.5 times around the patient, stop, spin backwards, move the table, spin forwards again. So very slow acquisition. Slip rings were developed and allowed spiral CT. And because of that, we're doing cardiac CT the way we do it today. And you know, I talked about Nobel Prizes. I'm going to just show you. Willy Kalender did the first paper showing that in 1989. And I wouldn't be surprised if he, in a few years, would be recognized for that with a major award as well. Here's that very first paper. That's it in its entirety, and it's changed how we practice medicine today, because today we only use spiral CT scanners using that slip ring technology. And then here's another guy who is a little bit under-recognized, Teruhito Moshizuki at the Ehime University in Japan. They did present in 97, but in the years before, they used spiral CT, not MDCT, single slice spiral CT, to create the first images of the heart. Look at this. This looks like a volume rendered image today. Sorry about the quality of the video, but you can see the four-chamber, the short axis view. You can see cine images of the heart. How did they do it? Well, they recorded an EKG. Then they had one of their residents painstakingly record with each cardiac cycle, with each arc peak, they recorded where the gantry projection is that corresponds to that point in time, resort the data manually, and re-reconstruct everything manually like that. And these are some of the images. These are just some slices going up and down. And you can see the coronary arteries in some phases. You can see the coronary arteries rather nice. So legend has it that Dr. Mochizuki talked with one of the engineers of Siemens who were also kind of thinking about this kind of stuff at RSNA in 1997. And then soon thereafter, Siemens came out with a product that does exactly this, which is what we do today with multi-detector slice CT. First paper on multi-detector slice CT of the coronary arteries, or one of the first, again from Stefan Achenbach, looking at 4-slice CT, giving us another example of a high-grade stenosis confirmed with cath. Okay, so the new era of cardiac CT was basically born. Okay, let's talk a little bit about how that was 4-slice. The gantry rotation is like 500 milliseconds, right? 500 milliseconds is a lot of time to take a picture. Imagine having a camera of an athlete and the shutter speed is half a second. We use 1/1000th of a second to not have blurry images, right? So we use cardiac synchronization, prospective or retrospective gating, and data reconstruction using these algorithms. Let me go through this. So at that time, if you did a cardiac CT, it would take half a second to get this image because it takes about half a second to rotate around the patient. Okay? In half a second, there's so much motion, you cannot see the coronary arteries. It's so blurry. By the way, this is how we display the phase in cardiac CT. And you can see that this box has two characteristics: a position on the EKG with respect to the R peak. Where is it? It's in systole here and in a little bit diastole. And a width, how wide it is. How wide it is your temporal resolution. You see these boxes on your EKG, on your scanners, and look at the width. The width tells you what the temporal resolution is you have. So if this is a 1 second, this may be 420 milliseconds. So the trick is to throw away half of your data. Throw them away. Normally, if you throw away stuff, you have less. It's not as good. But if you throw away half of the data, it takes only half the time to get the image. And look at that, the box is only half of the width. And now if you time it, the box, the acquisition with respect to the EKG, so that it ends when your atrial kick starts, when the P wave starts, then you have a temporal resolution instead of 420, now you have 210 milliseconds. And look at that, the coronary artery, it went from this to that, sharply outlined. Okay, so throwing away half of your data and positioning it late in diastole when the heart's most quiescent allowed us to get coronary CTs. Now, the longer your diastole is, the more time you have to find the sweet spot. That's why we give beta blocker on heart rates less than 60. So what happens when you scan? You acquire, maybe with the modern scanners, 3 rotations through a patient. And you collect all the data. And then in retrospect, you or the tech tells the scanner, give me a reconstruction at 50% of the R to R interval. Like halfway in between is 50%. Okay? Out here would be 90. And then the scanner goes in and it automatically picks the exact matching projections in your sinogram and creates a stack of 64 slices or so. If you then look at the images, see if there's motion artifact. And if there is motion artifact, you can say, okay, give me something else. How about 80% or how about 75%? So in retrospective gating, you can put that phase wherever you want. You can create one in systole. And if you look at this myxoma here in CT, the mitral valve is closed, right? Because you're in systole. And you can create something in diastole. Look at that. The mitral valve is now open and the myxoma has prolapsed into the annulus. So you can get 10 phases and get cine images. And that's exactly what we do when we do retrospective gating, okay? So here are your 10 phases, and then you get this cine image in cardiac CT. So that's how we are able to get cine images. Okay, so then in 98, the development was really fast. We got 4-slice CTs, 16-slice in 2002. In 2004, the first 64-slice scanners came around. And then lastly, we had the 320 and beyond and dual source. And you can get fantastic images. This is an older 64-slice CT scanner with a mechanical single disc tilting valve, Medtronic Hall, I believe, valve here. This is just fusing a 3D view with a 2D multiplanar reconstruction. And you can look at cardiac function in any view you want because you have a volumetric data set. So you can get a CT ventriculogram, you can get a 2-chamber short axis or a 3-chamber view. Okay, so with 64-slice CT, which now is considered the minimum requirement, you can get these kind of images and perform well if you do good heart rate control in your cardiac CT. But patients with higher heart rates, would benefit from even newer technology. All right, so up until 64-slice CT, all the vendors in their development went in one direction, and then they went in different directions. So they did dose reduction strategies with iterative reconstruction, temporal resolution improvement, dual source, faster gantries, dual energy imaging, and spatial resolution. We had a prototype you may know that, Hector, the flat panel CT system, which used a digital mammography type detector, not the usual detector on one side, and then a regular X-ray tube on the other one. And to date, I challenge you to show me cases that show you better images of stents. So what you can do is you can look at these tiny vessels, 200 microns, and look at them start flushing into the myocardium. So that's great, but this is, of course, a pig heart in a bucket, not a heart in a human body. And just look at these stent images. The resolution is really unmatched. This is a 2.5 millimeter stent, and this is a, fraction of a millimeter mimicked in-stent restenosis. And this is what I wanted to do. We're scrolling through the stent, and you have that kind of resolution. That's unmatched even with the ultra-high resolution CTs. But you can already see it says dead end. The problem with this detector is they have an afterglow, so you can't spin fast enough to get images that are in a human being that are good. So maybe we will not see that in the near future unless we get better detectors. And then this one is a game changer, of course, or was a game changer. This is the 256-slice CT, which once they got FDA clearance, they actually switched them all to 320-slice CT scanners. But this is the prototype that they used in Japan. And I was actually privileged to present some of their work. This was in 2005, mind you, when it was new. And Dr. Moshizuki gave me this image of a Japanese lobster that was moving, not like the heart, it had to go in the same place, but you can see the thing move in 4D. So today we've seen 4D images, but back then that was kind of cool. So yeah, and of course we still use that. All right, so then there's other stuff. We did things like Siam based, sorry about that, let's try this again. Siam based CT, where you use a C-arm and you rotate them around a patient and you get multiple shots, and then you use those X-ray images basically to reconstruct your images. And let me just go here. So this is how the unit looks. You would inject 25 milliliters in the aorta, rotate around it. It took 5 seconds to rotate, and then you would get an image that looks like an aortic invasive angiogram in 248 projections, and you'd use a different algorithm to get to the images. So at MGH, we were looking at this to see whether you could do this in a TAVR case instead of the CT. Is it as good? And of course, if you look at the images on the left here, all you see is the contrast in the aorta, because there is no contrast in the ventricle, because it never was injected, right? But we figured the measurements, they came out to be about the same. So you can do it. But you have to stop everything while you do the procedure. It takes a long time to do the measurements while the catheter is in there. So it's operationally not really feasible. So we still do the CT, but that was cool technology. And you see the images, the difference in the 3D. All you see is what you injected, the aorta. You don't see the heart, where you do see that when you do a regular CT. Okay, then GE did the rapid KV switching or higher spatial resolution algorithm as their next development. Siemens did the dual source to have faster temporal resolution. I can only recommend this because temporal resolution is the most important part in your CT system. You can see they have two detectors, A and B, and one is bigger than the other, and they rotate around. So your temporal resolution here is not 1/2 a gantry rotation, but 1/4 the gantry rotation. So twice as fast by doing 2 X-ray tubes on there. And then there is a wonderful company in Israel, Avi Netta. By the way, the founder, one of the 2 founders' daughters were Ari and Netta, their first names. So that's how they named the company, where they put two X-ray tubes on, not in XY dimension, but in Z dimension, one closer to the head, one closer to the bottom. And with that, they were getting cardiac images with only 8 centimeters worth of detectors, which is the most expensive, not 16 centimeters worth of detectors, but they were able to cover the whole heart. Right now, GE is the company that sells those scanners, and unfortunately, one of the two co-founders has died last year. But I was able to visit them in their factory, and this is how the machine looks when you have the gantry open. If you put your finger in there, you will have one less fingers. Okay? That's why we have the plastic covers, otherwise nobody would go on these scanners. All right, and then so there are two approaches. One is the photon counting, and one is the Aquilian one. The Toshiba, Canon now got bought Toshiba approach to ultra high resolution CT. This is relatively early, but there's some data out there showing that you can have better stent images using the ultra high resolution CT. Not quite as good at the flat panel, but you can do it in living people, which is of course a big difference. All right, here's a paper from Radiology Cardiothoracic Imaging, one of the first one looking at the accuracy in patients with extreme amounts of calcium, which normally makes it hard for us to look at the underlying lumen. And they show us that you actually do get really good image quality for that. And then, of course, there's photon counting. This is like the first publication from Dr. Blümke's group in humans that used a photon counting CT scanner. And now you can buy it from that particular vendor, and others have prototypes out there. So we'll soon see more photon counting CT. These are the images that go with that. And then there's spectral CT. We had the privileges in Dallas to have a prototype of this. It's the Siemens approach. They call it Icon, where you have two layers of detectors. The detector is not just one. It has a smaller low energy and a larger high energy detector that separates the energy of what you see. And if you do that, you can actually tell for each pixel what is the Compton and what is the photoelectric component of that pixel. So bear with me for a second. If you have that, you can actually identify what material, like I mentioned earlier in the MR talk to the residents, MR is great for tissue characterization. Now with that, you can do tissue characterization with CT. We felt it's really exciting. We did a lot of studies, some studies on that. This is a little bit of that CT fingerprint. And if you go and you circle the CT fingerprint, you can project it back on the image. So this, we have selectively identified silicone. In this person, you can see silicone is showing up here. And in this patient, we circled another region, and that region shows you selectively cartilage. Okay, so this is pretty new. This is an outlook in the future a little bit. We have a paper out. I'm just showing you that because we made the cover of Radiographics, so I'm showing off. Sorry about that. But it's a nice read if you're interested in dual energy imaging and vascular approaches. I think we will see some of that in the future. And it also is the first paper that shows one of those CT fingerprints that I just showed you. Okay, so if you have that, you can use new contrast agents. We use iodine, maybe gadolinium. But there's other things like hafnium or so, that if you give it and you do a virtual reconstructions, the hafnium will still remain where the iodine in the kidney. So these are mice, and they've had iodinated contrast in the arteries or veins, and they had in the bowel, in the gut, and the stomach here, they had this hafnium contrast. So you can selectively turn off one or the other. So you could inject multiple contrast agents at the same time, or inject them at different times, I should say, and you get a delayed and an early image at the same time. Or you can turn enteric contrast on and off if you're looking for polyps or something like that down there. So we may be seeing new contrast agents in the future. And then we do strain with MRI, which is really cool, but you can do it with CT as well. There's some work that a colleague of mine shared with me in Mexico, I believe, at a meeting, doing some circumferential strain. This is relatively early for CT, but we've seen the first research papers coming through, and it might be actually a routine analysis that we will be doing going forward as additional information. And then 4D flow MRI, you probably have seen that, very cool stuff. Can you do it with CT? Obviously not. We can't measure flow, except you can. This is a group that is out of Scandinavia. Jonas Lanz published this in Radiology Proper, where they did 4D flow based on morphologic criteria in a dynamic data set, and they gave us 4D flow MR versus CT. And if you look at the images, they look very similar, right? 4D flow MR versus 4D flow CT. And they could even, do I have it? Yeah. Show you the mitral inflow. Not perfect, but to me it's mind-boggling that you can get this kind of information out of CT. So this is also a little bit of an outlook and the technology that we will be seeing in the future. So it's a really great time. And if you use spectral or dual energy CT, you can get, if you have the hematocrit, you can get extracellular volume. You can see this is from radiology cardiothoracic imaging, where you see this CT extracellular volume map versus the MRI, the gold standard. So it's very similar to the gold standard, except it has much better spatial resolution, which, you know, I don't know, can't hurt. It looks good. I don't know if it is of benefit, but it certainly did do well in comparison with MRI, which we would use as the gold standard. So there is much more to cardiac CT than just morphology. If you think that, forget it. That was yesteryear. Today, there is so much more. Okay, so cardiac CT can do a lot. Why should we be doing cardiac CT? We have SPECT and PET, right? Radionuclide imaging. We have echo. We have EKG, stress EKG. Why do we need something else? Well, let's talk about cardiovascular disease. I'm going to give you numbers from the United States just because they were available to me. I don't think that's the most important country or whatever. They are available. So I'm looking at what's out there. In the US, it's the leading cause of death. So it's an important problem. There's 64 million people there that have some form of the disease. It's a huge economic burden. This is an older number. It's probably much more than that now. But $133 billion a year, that's quite something. The American population is getting older and heavier. Obesity is on the rise. So the problem will only get worse in the future. So important problem. We need to get it right. Okay, well, how well are we doing? Well, before we do that, let's look at some of the numbers since 2010. So this is also from our journal. Interesting journal, by the way. Articles are free. I'm not advertising. Yeah, I am. There. You should look it up if you haven't yet. Some great stuff. So it shows you the numbers done in echo, nuclear medicine, myocardial perfusion imaging, PET-CT, and you can see that cardiac CT has increased a little bit, but only very little over the last 10 years. Okay, so we're doing much less. So we're doing 16 times as many myocardial perfusion tests, like SPECT, stress imaging, right? Then we do cardiac CTs, and we're doing 10 times as many stress echocardiograms as cardiac CTs. So my question for you is, okay, should that be the case? Is that what the evidence is telling us? Well, I will review with you some evidence, and I'll let you make up your own mind, okay? I'm not here to tell anybody what to do, but let's look at this. Let's look at a time before cardiac CT was a player. So this study from 2010, Manish Patel and Pamela Douglas, they looked at ACC data. This is again from the US, from 663 hospitals, a lot of hospitals. So this is not a small study. And they looked at, okay, so if they go to the cath lab, did they go to the cath lab for good reasons? Okay, what is a good reason? Well, if you have an obstructive disease, potentially need revascularization or a CABG, that was a good reason. If you don't have obstructive disease, could we have prevented you from having to go to the cath lab? Well, this is what they found. They found no coronary artery disease in 40% of people that went to the cath lab. So 40% of people could safely have been spared from going to the cath lab. Okay, they felt that's a big number. If you look at obstructive disease, which they said less than 49% or less, 60% in the population in the US, 633 hospitals, that's a lot. 60% didn't have to go. They had nothing. No, nothing obstructive. They had non-obstructive disease. Okay. Their conclusion there was we need better strategies for risk stratification to inform decisions so we can increase the diagnostic yield in the cath lab. Because if you are in the cath lab, you want to be able to help, right? You want to identify disease and maybe treat it. Okay, so they felt, being cardiologists, right, that published this, we need something. Okay, let's see if cardiac CT could play a role here. So first of all, let's look at the data. So if you are a patient, okay, and you're coming, and you would look at the Framingham risk score category. Blue is low, yellow is intermediate, red is high. So if you're high risk, and you did get one of the non-invasive tests, you get your stress myocardial perfusion imaging test. And if the result was positive, if you were high risk by Framingham, less than 70% actually had obstructive disease. But if you look at the intermediate or low, even though you're symptomatic, you have a positive stress test, only 20% of the people with a low Framingham risk score had the disease. It's pretty low, if you ask me. Okay, but how about if it's negative? This should be like, nobody has the disease, right? Doesn't look that different to me. How about if they didn't know? Or if no test was done? Sorry. I don't know. This isn't really saying that having a stress test made a big difference. Right? Having a positive or a negative or I don't know or no stress test didn't make a huge impact. So we definitely could use something to help us better stratify who has it, ultimately in the cath lab. Okay, but how about, let's look at atypical, no symptoms, or angina. So if you are positive and you have angina, actually still, positive stress test and angina, you would think the patient has it, right? Only 50%, little more than 50% with positive tests had it. Hey, if you had no test, the same number had it. Hey, if you had a negative test, a little more than 40% had it. So that's surprising. This is from 633 hospitals. That's a huge number of patients. Okay, so we need something to help us better understand who will actually be benefiting from revascularization. Okay, so here's my question. Can you have your fellows in your CT lab be the gatekeepers to the cathedral, the cath lab? Does that make any sense? Should you do a CT to help you know who will benefit the most from going to the cath lab? Because you want to get the people that will benefit from it in there, and the people that don't need it probably shouldn't go. You will have a higher yield, more interventions, usually makes our interventional cardiologists happier. Okay, so let's look at some data. First of all, when I started out doing this stuff, I always had to apologize because there isn't enough evidence out. And yeah, look at the evidence. And in case you didn't see the trend, I put an arrow on it. Yeah, there's a trend, because we're doing more than 1,000 papers today on coronary CTA, so there is a lot of evidence. There's more evidence than for most other things that we routinely accept as useful. Okay, we'll have to see what the evidence says. But how about the temporal resolution? It is so slow. Yeah, what happened in my time alone, the temporal resolution went down to, with the right scanners, like a dual source, it's like just above 50 milliseconds. So that's a fantastic technical development that happened in the recent decade or 2 decades. This is unprecedented, and cardiac imaging drove this. We drove this. The vendors were listening to us and asked what needs to be done. And what's even cooler, I was told, I'm using so much radiation on our patients. Look at this chart, look at that. See, in the near future, we will be sucking radiation out of the patient. It is so cool. I just learned the most phenomenal fact. And if you're listening on the Teams, or if you're in the room, you should really think about this. More than half of the patients scanned on cardiac CT here, by your team here, has a millisievert or less of radiation. That is phenomenal. That's a huge success. You can be really proud of the team you have here. I am. I didn't do any of that, but what a great team. I'm proud to know some of you. Okay, so that's fantastic. Very low radiation dose, like 1/10 of a nuclear stress test, right? 1/10 of your PET CT. That's pretty cool. Okay, so radiation is no longer an issue. It was in the beginning, 20 years ago, but isn't. Okay, how about the literature on stenosis? How good is CT in even detecting stenosis? Well, let's go to the beginning. The first papers looked at the cardiac CT, and they had a reader say yes or no, it's more than 70%, or yes or no, it's more than 50%. Or in the beginning, they were allowed to say, I don't know, or non-evaluable. There is too much calcium or motion artifact. And compare it with invasive angiography as the gold standard. So this is great for, invasive angiography because by definition, they had 100% accuracy because we called it the gold standard, which we know, though, there are some scenarios where they're not always right and where information from a CT could actually help influence the reading. Well, in any case, there's some meta-analysis looking at hundreds of single-center trials, and they showed all that the biggest thing is the negative predictive value. So if CT was able to say there is no significant stenosis, you had unprecedented high negative predictive value. So you could be really sure that there isn't a stenosis. I would go so far, if you know that there is no plaque and no stenosis, and you have good image quality, you can be certain there is no epicardial obstructive disease. So that's pretty good. No other test will give you that kind of accuracy values. Then, well, that's meta-analysis of single-center trials. That's, good evidence, but not great. This is prospective trials showing you also very good negative predictive value. The core 64, they allowed the readers to say non-evaluable, and then they made them say every non-evaluable segment is positive or negative, I forgot. They made them call it something that they had no knowledge about, and that's why the number is so relatively low here. But how about the clinical data and events? So if we have a calcium score of 0, by the way, this took me 2 hours to make this movie here, and right now you open the software and it's like automatically there. You have to do nothing. Well, early on, we had all these papers that looked at the few years after the CT and the event rate, and all of these said if you have no plaque and no stenosis, you have a close to 0 event rate. So 0 calcium score, but also no non-calcified plaque. The event rate was very, very low. Okay, very powerful information. Okay, so I want to go through some of this stuff, but this is when I gave my way ahead lecture for SCCT when I became president in 2018. At that time, we looked at much more than just stenosis. You can look at plaque morphology, perfusion, physiology, FFRCT, and 4D flow, as I mentioned, and then function, of course, strain, tissue characterization, and all of this will lead, and I will show you, hopefully convincingly, that will lead to precision medicine and better patient care. So you will be better equipped to know which patient will respond to what therapy. Okay, so how did we get there? This is an early one from Germany, looking at more than 2,000 patients that had suspected coronary artery disease in the 64-slice CT, looking for death, MI, and stable angina, or revascularization is 90 days at the outcome. Clean coronaries, no events. If they had plaque but no stenosis, very few events, 0.3%. If they had stenosis more than 50 or 75, they had a 4% event rate. Okay, so having a stenosis on CT means you are at higher risk for events, and having no stenosis means you are at very low risk of having an event. And having clean coronaries, they had 0 cases. Okay, then Jim Min and others, Jim Min was instrumental in forming the confirmed registry, which now has more than 50,000 patients in it. This was earlier on at 27,000 patients looking at plaque. Do you have normal coronary arteries? Do you have non-obstructive plaque? Or do you have 1-vessel, 2-vessel, or 3-vessel obstructive disease after 3 years? Just look at that. The effect size. This is like 6% of people with 3-vessel disease are no longer alive. This is all-cause mortality. So not only can you predict outcome, the effect size is really big. So this is very powerful predictor for future events that you get from a non-invasive test. Okay, so can treatment do something about it? This is, I understand Dr. Achenbach has talked to you. These are slides that he gave me. He's a good friend. Looking at a similar 0 to 3 vessel differentiation with a Kaplan-Meier curve here, in patients, 10,000 patients that didn't have a stenosis. Okay, so yeah, 3 vessel disease was worse than 2, worse than 1. Okay, so if you now look at the ones, you look at treatment, you look at the ones that had non-obstructive plaque. They had plaque, but no stenosis. Okay, plaque, but not a stenosis. Nearly 5,000 people. And the ones that were on statin had much better Kaplan-Meier curve here than the ones that did wear on statin. It's nearly less than half of the events occurred if you were on statin. So if you have plaque, even if you have no stenosis, like you do a cath and you have clean coronaries, you still don't know if there's plaque, right? If you do a CT and you have no stenosis but you have plaque, and if you put your patient on statin, they will have half the events compared to the one you don't put on statin. So that's pretty powerful. Okay, so why don't we do it for everybody? Well, if you look at the patients, that's nearly 6,000 that had no plaque at all, there was no difference whether you gave them statin or not. They had about the same event rate. That was not statistically significant. So if you don't have plaque, statins didn't make a difference. If you do have plaque, they made a huge difference. Okay, so I mentioned precision therapy. So in whom to give your statins, especially if you're like on the fence, you're like, should I give it or not? Well, if you have knowledge of presence of plaque, you know you will be doing something good for your patient. Okay, how about this? 13,600 patients looking at the outcome of death, MI, or stroke, so any cardiovascular, including stroke. If you look at the patients that have calcium, this is calcium only, patients that have calcium, if you give statins, they do substantially better. They have a statistically significant lower event rate. This is not as big an effect, but still statistically significant lower event rate than those that don't get any statin. Okay, well, how about those that don't have any calcium on their calcium score? Well, here's the curve. This is actually 2 curves, and they're so identical you can't even tell, hence the 2 arrows. So you have, if you have no plaque, first of all, you do better, right? You have a much lower event rate than if you have plaque, right? And if you give statin or no statin, made no difference in these 13,000 people. Okay, so treatment isn't just, you can't just, well, you can, but perhaps if you only use the Framingham risk score to know who should be on statins, who shouldn't, and your lipids, you go only so far. If you have now knowledge of the presence or absence of plaque, you will know in whom you will make a difference by giving the statins. Very powerful data, if you ask me. Okay, so then there comes the first practice guideline, and this is not, I think, quite the one you had in mind, Hector. This is the one for cholesterol. This was the 2018 guideline, where for the first time calcium scoring, because of the data and some others that I showed you, was acknowledged. And calcium scoring had become a 2A indication. So people with intermediate risk, sorry about this, or borderline risk adults where the decision about statins remains uncertain, so you don't know, maybe the patient is hesitant, it's reasonable to use calcium scoring in that decision. So this was big because calcium scoring wasn't really acknowledged in the US in these multi-society guidelines. So since 2018, it's in there as a class 2A indication. So great. I thought, what took them so long, finally? But I guess they wanted the hard evidence. Okay, let's talk about chest pain, symptomatic patients, acute chest pain. I want to start off with the patient. I don't know, Hector, if you remember this case or not. This was ROMICAT 1. Maybe it was a little bit before your time there. So ROMICAT 1 was a trial where patients came to the ED. They were not cleared, they were not ruled out for acute coronary syndrome. So they were admitted for 1 day to do the observation. The ones that are ruled in, you measure the door to balloon time, they go straight to the cath lab, right? But these are the ones that would be admitted. So we're like, hey, how about we do one of those fancy CTs just before you get admitted? And we'll keep it blinded because we don't know how good CT is. We don't want to influence your decisions based on the research test. Okay, so this guy was walking on Charles Street right outside of MGH and got chest pain, radiating into the arm, pretty bad. He knew something was wrong. He walked in the ED right then. Troponins negative. First EKG was red negative. Later on in retrospect was red indeterminate by Dolph Hutter, right, an advanced master in EKG. But that's how he showed up. So they're like, yeah, let's admit him. Let's do one of those CTs. So we did the CTs, and then I saw this. And this is the moment I got chest pain myself. I'm like, oh, shoot. I thought a different word, but I don't think I can say that here. And I looked at the patient. I'm like, this I thought was an LAD occlusion. Actually, it turns out this entire thing is the LAD. That's the first diagonal. Here's an anomalous RCA. There's no contrast here. There's plaque. Look at that. No contrast in the vessel. You can't see it. Look at the RCA. That's how it should look. Where's the contrast? I'm like, oh my God, this is an acute. So there is no myocardial thinning, no aneurysm. This was not chronic, right? This is an acute occlusion, complete occlusion of the vessel. So I unblinded this patient. I called the PI, which is Udo Hoffmann. I said, I have to unblind it. I unblinded it. They were a little bit, really? Yeah, your research test showed that? Okay, sure. And then I heard in the background, the second troponin came back and was sky high. And they're like, oh, thank you. Yeah, we'll take him to the cath lab. So it wasn't supposed to unblind people, but we did. So this guy got out of the blinded part of the study. So, the RCA still images had some plaque, but no stenosis. As I mentioned, he had an anomalous circ. It had a significant stenosis, but that was not the culprit lesion. And then the LAD completely occluded here. Let me just show you a few other images. So, hey, you get function for free if you do a retrospective. See this? I mean, my mother can see this. There is, right? Let me just close. I'm sorry, my mother's not in medicine, but she's a smart lady, right? What's going on there? Can you see it? Oh, it's, yeah. Why is it not doing this? Let's see if I can fix that. This is not contracting. Everything else is contracting. This is the mid to apical anterior free wall, which is this area here. Let's see. Look at that short axis. You get free additional information. We just talked about stenosis and morphology, but you get all this for free. This myocardium of the ventricle is whiter than this. There's a complete absence of perfusion. And looking at that, it looked to us like maybe there's thrombus, but maybe it's just slow flow at the apex here. Okay, so like, wow, why does this happen? Troponin, they take some time to convert. If you look 4 hours later, only 40% have converted. Even high sensitivity troponins, if you look after some time, well, sometimes a lot of other things. You run a marathon, it will be positive. So if they're low grade, they're not always very useful. And this starts actually at the time of presentation. And our guy was so early with the presentation, we don't know how long it takes for the high sensitivity troponin even to convert. Okay, so this was an unusual case. You shouldn't be seeing that in your cardiac CT group. Unless it is maybe so hyperacute that it gets missed by your standard care. So here's the result from RoMICAT. Let me just remove some stuff. If you looked at all patients, 103 of them were in that trial, and you look for stenosis, your sensitivity was 100%, nobody got missed, but the positive predictive value was only 20. This was any plaque was only 23. But that actually, believe it or not, this sounds terrible, but it makes a big difference. And if you looked at stenosis, more than 50%, the positive predictive value, yeah, you caught everybody, but the positive predictive value was only 47. So is that any good? Well, let's look at it. 103 patients, all of them would be admitted with your conservative treatment, right? With the CT, only 29 would have been admitted. So you would have sent safely home 72% of these patients that didn't have to stay a whole day, maybe get their nuclear stress test the next morning after the 3 troponins, which is what they used to do at the time. And then if only 1 in 2 has the disease, or as opposed to 1 in 10, you have substantially improved the care you can deliver with the same resources you have. Okay, but that was blinded. We didn't tell them, except for that one person, right? So how about if you tell people and you let CT be part of the decision making? Well, this is one of the first patients that did that. Nearly 500 patients with acute chest pain, they told them they discharged 84% based on a normal CT, and they had no events after 30 days, and they had only 1 event of an unclear death after 1 year. A patient dying in fulminant liver, what is the word? Liver cirrhosis with fulminant liver failure. So I'd say it's safe to assume that was not cardiac, but for the paper they had to put it in as an unclear death. So nobody got harmed. If you actually now allow the team to know what the CT said, okay, great. So using CT actually improves this. And then there were three major trials. ROMICAT 2, multi-center trial, looking at 1,000 people, half of them standard of care, half of them with CT. They told the CT result right away, and they looked at the outcome of length of stay. How long have you been in the hospital? And if the final diagnosis was not acute coronary syndrome, your length of stay has reduced substantially, nearly half as long. If the final diagnosis was positive, then there was no difference because they'd have to go and admitted and worked up and treated. Okay, so these are the curves. In blue, the CT arm. In red is the standard evaluation. Length of stay in hours on the bottom, proportion of patients discharged. How many percent were discharged? If you look at how long did it take to get half the patients out of your ER? Well, 8.6 hours. Half of them were gone with the CT arm. So if you have the same number of beds, now you can see twice as many patients. That should be attractive with the same resources. Where it took 26 hours for the standard of care arm. How about what happened after 12 hours? Well, after 12 hours, 62% in the CT arm were safely discharged, where only 21% were in the standard of care. Okay, so then Harold Litt did the Acr PA study, which is kind of looking at the same thing. They had 900 patients in the CT arm and nearly 500 in the traditional care. And let's see, discharge. They discharged half of their CT patients from the ED, but only less than a quarter in the standard of care arm were safely discharged. Okay, how about length of stay? 12 hours for the CT arm, 24 hours, twice as long if you didn't have CT information. So if you are an administrator looking at ED, efficiency, money, all of that stuff, you love this. This is really good data. If you're a patient advocate or family, you love this. If you're a cardiac CT guy, you love this Monday through Friday, 8 to 5. The love reduces a little bit on Saturday morning at 2 a.m. We all struggle with this. It's hard to do a 24/7 thing with that. Okay, so the CT STAT trial was looking at something very similar. This was Gil Raff did that trial. They've also found a 54% reduction of time to discharge. And they also calculate a cost reduction of 38%, which I don't know that this is really working everywhere because every center is different. But that's what they found. In the CT arm, there was cost reduction, at least in the short term. And all of these trials showed, let me just go back, showed no difference in outcome or major adverse events. No more events in the CT arm than in the conventional arm. Okay, so then there's, this is just a summary of what I just told you. Let's talk about other trials. Since then, stable chest pain. This is a pyramid. This is from Leslie Shah, which she presented that at SCCT and published it later. Single center trials, perhaps your lowest level, too numerous to put on there. Thousands. We have thousands of multi-center trials showing that it works. Then you have registries. Actually, it's missing the confirmers. Oh no, confirmers up here. So a number of registries are out there looking at hundreds of thousands of patients that we have data on today. So this is not small numbers. And then, of course, we have the prospective randomized control studies, the Hart trial, the PROMISE, the Ischemia trial, and most recently from Europe, out of Germany, but it's a multi-country trial, the Discharge Trial. So I'll review some of those because these trials informed the guidelines. That is really the reason why we're talking about all this. So the Hart trial in Scotland, it took about 6 weeks after you get your CT before you got seen by your primary care physician. So they did not look at the first 6 weeks because no change in care happened. So they looked at the time when patients were seen after the primary care or cardiologist physician got the results from the CT. And then they looked at, they looked at the proportions of patients that had an event, like a MACE, major adverse cardiovascular event. And in the CT arm, you can see there are lower number of events, statistically significant with a hazard ratio of 0.5. Ooh, if I want to be in that group, I can tell you that. So if you had a CT, you had much less events than you had in the standard care arm in a prospective, randomized, countrywide trial. So that's pretty powerful data. Okay, so that's why in the UK they came up with the NICE guidelines. Okay, then they did a 5-year follow-up looking at events, and look, it's holding up. This is the CT arm, and this is the standard of care arm. And the difference is 2.3% overall versus 3.9%. You know, you could look at that as how much is 2.3 out of 3.9. It's, I don't know, a 40% reduction of your personal event risk. That's pretty cool. So if you ask me, I would want to be, if I have chest pain, I would want to be in the blue group here and not in the red group. If you looked at coronary, so you could say, yeah, okay, but CT shows morphologic lesions and we don't know what it means. Don't they all get more cath and more revascularizations? And the answer is shown in that slide. No, they didn't have a higher revascularization rate. So it didn't lead to over-treatment. So that's not what it is. It's not over-treatment, it's more precise treatment in the patients that do need it. Then they also looked at medication. So in the CT arm, 14% were started on preventative care, and in 4% it was actually stopped. And despite that, you have this improved outcome. Where in the standard of care, nobody got stopped, or 0.4%, and only 4% got started after the patient presented to the study and was randomized in the standard of care. So you have much more treatment change, a lot of it conservative with lipids and so done. So precision, when you know there's plaque and you treat the patient, you will make a difference. So because of that, the NICE guidelines, the old one didn't have cardiac CT, and then the new ones, if you have angina, you basically have coronary CTA if you have ECG changes and you have atypical angina. Okay, so that was early on, much ahead of the United States. The United States was much lower with that. Okay, so now the NICE guidelines were out. The whole country, the whole UK was using them, and they were treating patients accordingly. So how did they do? Did it work, or did it make things less good? Well, if you look at this, this is the invasive coronary artery frequency in patients with possible angina and with patients with no angina. There was an increase in patients that had no angina. You could ask, why did they even get a CT if they don't have angina? Shouldn't have, right? CTA, that is. Okay, but if you had symptoms, which you're supposed to have for coronary CTE, no difference in how many people got the invasive coronary angiogram. However, 2/3 of the 68% lower normalcy rate. So the ones that did get it had a higher yield. So you did your invasive angiogram in the right people. Okay, and they had a 40% fatal or non-fatal MI difference. So if you have no angina, it didn't make a difference. But if you had possible angina or atypical symptoms and you got your cardiac CT, it made the population better. So this is after NICE guidelines were implemented. How did the country do? Well, they did better by the numbers I just showed you. So that works. Then there's a PROMISE trial. The PROMISE trial was really a negative trial, but it did show essentially non-inferiority of CT over other trials. But if you looked at patients with diabetes in the PROMISE trial, you would find that the CT patients did better than stress test patients with the outcome of death and MI. So in select groups, the PROMISE trial was positive, and that particular one is diabetes. Okay, how about the Ischemia trial? Now in the Ischemia trial, as you know or probably know, CT was not used to make decisions. CT was used to screen out patients that had left main disease, so they wouldn't get enrolled, and also patients that didn't have obstructive disease. So they used patients that had a stress test, and the stress test said they had their mild or moderate disease, and then they were enrolled. actually, it turns out that 1,200 patients, 20% that were not included because the CT showed they didn't have any obstructive disease. So that tells you how good the stress test was, and that is in keeping with the data I showed very early on. And of course, they had 6% of the patients that showed up for the trial didn't get enrolled because of left main disease. So I would say there's a big role in CT there. And some of the criticism there is that 23% of the patients did cross over from the conservative arm to the revascularization arm. Okay, on to the Discharge Trial. This is one of the latest trials. This one is published in the New England Journal of Medicine this year. Paul Horvath and Mark Dewey actually is how you say it in Germany, but he's okay saying Dewey anytime somebody speaks English. They did a trial where they randomized people to either CT or cath for the initial diagnosis that were symptomatic, stable chest pain. Those were patients that were already scheduled to go to the cath lab. And they're like, okay, well, only half of you get to go. The other half, you have to do a CT first. Okay? And they looked at 3.5 years follow-up. The primary outcome was MACE, and the secondary outcome was procedure-related complications. So in the CT versus an invasive arm, they didn't find a statistically significant difference, but maybe a trend. P-value was 0.1, where CT had lower, maybe 1/3 lower number of event rates. So maybe they were underpowered, or maybe this is just no difference. But they did find a major difference in major procedure-related complications in the CT group versus in the invasive angiography group. Okay, and these are the particular complications that happened. So how about flow? So you can get not just morphology, you can also get flow with FFRCT, which FFRCT, of course, looks at a lesion, and it gives you the gradient and fractional flow reserve across the lesion. So you want to look at only what's within 2 centimeters of the lesion and not at the very distal coronary artery. So I'll summarize the evidence just with this slide. So there's a number of trials, many of which are sponsored by the company that does this, just as a full disclosure, but that has shown that it worked. The trials are here. They showed, they compared FFRCT accuracy to real FFR in the cath lab in 100 patients. And the clinical utility ultimately and the economic burden in more than 500, nearly 600 patients on the platform trial. So they're all positive trials showing that adding FFRCT in some patients, and the guidelines say between maybe 40% and they say up to 90%, I would say 40 to 70%, it makes sense to add FFRCT if you have that available to you. So based on all of that, and we're getting to the AHA-ACC guidelines, but first the Acr Appropriateness Criteria, who did this much earlier, I had the privilege of being part of that. It gives a green light, which is the highest level you can get for coronary CTA in patients with chest pain and possible acute coronary syndrome. So in the ED, cardiac CT is indicated or appropriate, usually appropriate. Okay, how about in patients with low to intermediate pretest probability and chronic or stable chest pain, CTA is also appropriate. This is what the American College of Radiology appropriateness criteria say. By the way, in the US, you may have to get pre-approval, and they want some of the things they look at. What does it say here? Is it green or yellow or red? Okay, and then there's the trial, the guideline we're talking about that gives a lot of guidance, not just the flow chart that I'll show you in a moment. It tells you what to do. If you have asymptomatic patients, for example, they say, hey, you don't test, don't do a coronary CTA. Maybe if you're low risk, you could do, you could do deferred testing if you know that your patient would benefit based on your Framingham risk score from lipids or not, or if you want to see if there is calcium, you can do testing. If you're in the intermediate to high risk, you can do anatomical or functional testing, which is a number of different tests that do include cardiac CT. And here's basically the flow chart. You have you have awesome world experts on the topic right here in Bogota, right here at this institution. And I would encourage you to consult them. There are some of the top people. But obviously, let's look at the stable chest pain for now. You do risk assessment. You want to see, are they high or low risk? And if your patients are intermediate or high risk, it's a class 1 indication for coronary CT based on all the information I have shown you. But cardiac CT shows up in a number of other locations as well. Class 1 is the highest level of indication you can get. So I will make this short because I think we're running out of time. Or how much do we have, Hector?
You can take as long as you want.
Oh, okay. So if you look at patients with acute chest pain, with intermediate risk with known coronary artery disease, and you look at people that had prior testing, you are in this arm on the left side. And if the prior testing is inconclusive or mildly abnormal, CTA may be indicated. Okay? If it is negative, no CT, you just discharge your patient. If the prior imaging has moderate or severe disease, you go to the cath lab, according to this arm here. Now, if you look at the CTA arm, it goes even further. If your CTA remains inconclusive, then comes the FFRCT or stress test. You could do a stress CT, you could do a stress MRI, you could do a stress radionuclide test, PET or SPET. Then, if you had no prior testing, so stable, intermediate risk with known coronary artery disease, with chest pain, without prior testing, you go straight to coronary CT or to stress testing. All the stress testing tests have a class 1 indication, so does CT. And then again, if the CT is inconclusive, you can go either decide to treat or you can go to FFRCT or to another type of stress testing at that point. So there is a number of class 1 indications or 2A indications for cardiac CT. And hey, there's a number of class 1 indications for all the other stress tests that are available. All right, so let's briefly talk about CAD-RATS, because CAD-RATS is our reporting system, and you probably see that in your reports if you send somebody for cardiac CT. And CAD-RATS has recently been updated. Oh, it says in press. It's actually, well, it's not. It's published, but it's not officially printed. So in press is still correct. It will be coming up in a couple of months. And the good thing about CAD-RATS 2.0 from 2022 and CAD-RATS 1 is that the CAD-RATS stenosis categories have not changed. So it goes from 0 to 5, and basically 0, 1, or 2 are non-obstructive disease, period. 4 or 5 are considered obstructive, either severe stenosis or occlusion. And then 3 is considered potentially obstructive. So where does FFRCT or other stress testing come in? Well, in this category, 50 to 69% luminal narrowing is a good one for FFRCT. That's what we do. Sometimes you do somebody who has a 45 or a 75 stenosis, but most of them fall into the CAD-RATS 3 category. Okay, so I'm glad that didn't change. If you look at 4, 4 is the only one that's subdivided in 4A and 4B. If you have only 1 or 2 vessels, it is a 4A. If you have 3 vessel or 3 vessel equivalent obstructive disease or left main disease more than 50%, then it is a 4B. So the cutoff is 70 for a 4, except for left main where the cutoff is 50%. Okay, so that's the CAD-RATS category. They didn't change. What did change? Well, some of the modifiers did change. So there used to be a modifier V for vulnerable plaque. That changed, only the terminology changed. It's the HRP high-risk plaque now. You have an N for non-diagnostic, because every once in a while we still have non-diagnostic segments. And then you have a new category of I for ischemia. So I is either not given if you didn't test for ischemia, or if you did test, you call it I plus if it's positive, I minus if it's negative, or I plus minus if it's indeterminate. And this could be either FFRCT, or if you did a stress perfusion CT with regadenoson or something like that. Then another modifier is stent or grafts when these are present. And the new modifier E is for exception. So let's just say you have a huge pulmonary artery because you had a PDA, right? And the pulmonary artery is externally compressing the left main. So you have a stenosis, but it's not due to atherosclerotic disease. You give the modifier E because otherwise you don't tell the full story. Okay, then there is another modifier which has its own slide here with a table, and that's the modifier P. Remember, I showed you that the more segments you have that have a stenosis, the higher your risk is. Okay? Not a stenosis, that have plaque, I'm sorry. So you quantify the plaque. If you have a CAD at 0, you don't give a P because there's no plaque. It goes from P1 to P4. It's supposed to be mild, moderate, severe, extensive. The easiest or the cleanest is CAC. If you do calcium scoring, these numbers tell you what you should choose. The second, perhaps best, is the segment involvement score, which just means how many segments have any plaque. Like you count them. Okay, the left main, 1. Mid-LED to distal RCA, 3 segments. Segment involvement score is 3. With that, you go to P2. Okay, so that is the number of segments you have to have. And then the one that is perhaps the most subjective is the visual assessment. I didn't like that, but I was overruled. I was part of the writing group here. And it looks at 1 to 2 vessels with mild amount of plaque, because not everybody does the quantification. And then if you have moderate plaque in 1 to 2 vessels or 3 vessels with mild plaque, it's a moderate. And you can read the rest here. So I'm not a fan. So what we do at our institution, when we give the P, I say it's based on this. And if the P is different for the segment involvement score, I say it's P2 based on CAC and P3 based on the segment involvement score, to be as transparent as I can, because there can be discrepancies depending on which method you use. So I just give all the information. All right, so what do you do with the ischemia? As I mentioned, there's I plus, I minus, or I plus minus. Well, if you did do an FFR CT, you'll send the images, you'll get it back from HeartFlow. Is right now in the US the only commercially available FDA-approved device or company that offers that. Well, if the number is less than or equals 0.75, then you would call it positive. If it is 0.6 to 0.8, you give it a plus minus for indeterminate. And if it's more than 0.8, you call it normal, I minus. Okay, that's how the I plus, I minus goes in. If you didn't do FFRCT, you did a stress perfusion, then it depends on your stress versus rest. So of course, if you have a mismatched defect, then you have ischemia, you give it an I plus. If you have a fixed defect, it's an infarct, you give it an I minus. And if you have a defect that gets bigger at stress, then you have an infarct with peri-infarct ischemia, then you give it an I plus. And if you can't tell, you can do I plus minus. Okay, so that's how you do CAD-RADS 2.0, and that brings me to the end. And if there's any time, I'd be happy to address any questions. Thank you very much, and I want to thank all of you again for the opportunity to speak with you and for your tremendous hospitality.
Thank you so much for your outstanding conference and slides. Are there any questions from the public?
Thank you, Dr. Abbara. It was incredible. What would you think is the gap that is missing so we can get more done the FFR in CT? Basically, it's only because HeartFlow has a very complex license, or it's just because any other software cannot have it?
So this is a complex business environment with copyright and patents and so forth. So HeartFlow right now there's a lot of products out there that are using dynamic fluid calculations or AI, which is completely different, that give you the same number at the end, but different method. So maybe in the AI space, we will see another company. But for the other one, there's patents so HeartFlow, I think, in their own interest, and I can get it, doesn't want other competitors to come up. So the more, we have only one company that can do it legally right now for clinical use, that's HeartFlow. And whenever you have that, the more competition you have, the more the prices go down and stuff like that. So we may see something in the future. I don't think in the very near future, but there's many products out there that can give that to you right now. Now for us, HeartFlow, I think it's $1,500 for one test. I get paid a small fraction of that, so it costs more than I make to get the HeartFlow analysis. So the insurance companies have looked at the data of the money they can save by adding that, by having a better diagnosis and better treatment, and so a lot of insurers are paying for it in the US. Yeah.
I have a question, Sunny. So the 2021 guidelines are like kind of partition the history of collaboration between societies, because the American Society of Nuclear Cardiology said we're not going to participate, and the reason they're not going to participate is because, as you showed also in the ACR guidelines, nuclear stress test stopped being a 1A indication, and in individuals younger than 65 years of age, it became the number one or the most preferred way of stratifying patients with intermediate to high, or depending on what paper you read, or intermediate risk of having coronary disease. We had a nuclear people here last week for a conference that we organized, and they said that the reason for the ASN, the American Society of Nuclear Cardiology, to withdraw from the guidelines was the FFR. I have a different interpretation of the facts, but you're a world expert. What is your take that on the 2020 guidelines, for the first time, a committee or an association as strong as the American Society of Nuclear Cardiology decided to withdraw? Was the FFR part, or just the fact that, as you very elegantly showed in your talk, there's so much there's so much evidence and thousands of patients showing the benefits of coronary CTA that eventually the evidence was so overwhelming to put CTA for the first time ever on the 1A category for individuals younger than 65.
So I have a bunch of friends that were on this many-year-long writing group, and the nuclear imaging community and society were part of it, had influence on the content, and really at the very last moment didn't endorse it. From what I understand from an editorial they wrote, is they want a patient-first approach, and they felt that this wasn't patient-first, but from I don't understand it. From what I see, that guideline puts the patient first, has listened to every stakeholder in the medical community, including nuclear medicine, and came up to this conclusion. I'm not a very political guy, but I think this will be viewed in the future as a historic mistake by that society. Am I going to get kicked out now? Yeah. So you've seen the evidence. How much more evidence does one need? I have not heard an official statement about FFRCT being an issue. I personally feel that FFRCT has been kind of a little bit overemphasized as well, but there is strong data supporting it. There's a lot of data for it. And to me, this guideline is all about all the modalities. And as you can tell, a lot of class 1 indications for all the stress tests were in there. They didn't pick a winner and a loser. They picked one winner, and that one winner in that guideline is the patient. They also told us, if you remember the pyramid, when we shouldn't do anything and when we should do something. So I always think we all, whether we are part of a society or an individual or a hospital, we should put the patient first and do what's best for the patients. I think the guidelines capture that really well. They're really good guidance. I think if I look at the number of studies done for this and that in the US, we're kind of slow to adapt. But the guidelines are really a good reflection of the evidence that's out there today. And, well, they give guidance to all of us how we should manage our patient with one constituent group in mind, and that is the patients and their better outcome. So I'm hoping that what I've shown you in terms of evidence, I don't want to talk about other modalities and whether they're good or not. I'm just focusing on what I know and how much we, the cardiac CT community, have developed evidence when challenged to do so, and what the evidence is. And to me, cardiac CT is really a success story from the perspective of a patient. Now, when it's time for me to know whether or not I would benefit from being on Lipitor, well, I know now what to do to help me inform that decision.
Thank you. More questions?
Sorry. Doctor, I'm a big fan of FFR, and I do believe it is the way it should have been a coronary disease studied for a while now, but it hasn't taken the importance it should have taken. Why do you think that is? And I mean, the evidence is clear. Otherwise, that the fact that is not time efficient for the interventionalist or for the hospital in order to get the patient out of the hospital. What do you think is keeping FFR from keeping the motion?
Well, I think FFR CT is doing really well. They're well established in the US. There's a lot of it is being done. They add a little bit to CT, but I think most of the power is in the data of the CT data set and in good hands, like they are here, right here. Most of the benefit you derive from FFR CT is from the CTA alone. You know, one of the things FFR gives you is it gives you like a core lab read of your morphology, which is an added benefit if you're, say, if you haven't done CT for 20 years, for example, you know, and you're not super comfortable. Well, they basically have people that do the segmentation, which is something, you know, you could be doing for you, and they help you in your interpretation. But FFR CT adds only in those patients where you have potentially obstructive disease and you're uncertain. Unfortunately, you may remember the accuracy curve with respect to luminal narrowing that got published in JACC that shows like right where you need it the most, the accuracy goes down. That's why CADRATS 2.0 gave you the I plus minus for when it is between 0.75 and 8, the FFR. So that's where you need it the most. But if you are looking at a 45% luminal narrowing, it really doesn't add something to this particular patient. Sorry.
Más preguntas? I have one very last one because we definitely exceeded time. And again, thanks for taking all the effort to put the slides together. Do you foresee a randomized controlled trial of coronary CTA versus stress MRI? And I know you're a CTA guy to the core, but do you think, is there equipoise or there's a good reason for doing that in the future?
Well, you know, one is looking for ischemia and the other one really isn't, per se. It looks for obstructive disease. Secondary maybe ischemia. If you wanted to design it, you would have probably to do stress CT versus MRI. But my question is why? If you look at the number of what people are doing in the US at least, CT is not MR's competitor. So I think stress cardiac MR is a fantastic test, and I don't understand why we're not doing it much more in the world than we're doing today. No radiation, great answer. You get all this extra information from a cardiac MR. So in my view, it is perhaps more underutilized than CT is. But I don't see coronary CTA and MR as some sort of competitor. And when you do a comparative analysis, I would always go to what's considered the gold standard. What is considered the gold standard? Well, cath with catheter FFR may be the gold standard for that.
Okay, thank you, Suhny. Anyone else? Bueno, muchas gracias a todos por venir. Thank you, Suhny. Thank you for a spectacular talk and for taking the time to come here and lecturing us and learning from a world expert. Thank you much.
Thank you.
Gracias.
People all over the world are united by a shared aspiration to live a healthy life. Helping people to live healthier and longer is the reason we exist. At Siemens Healthineers, we pioneer breakthroughs in healthcare for everyone, everywhere. The world needs groundbreaking innovations to fight the most threatening diseases like heart disease, stroke, and cancer. Where time is of the essence, our solutions allow for faster diagnoses and decision-making. Our novel photon counting technology is the beginning of a new era in imaging, providing previously unseen levels of crystal clear detail. Where precision takes priority, we provide the latest in robotic and image-guided therapy. And together with Varian, we are taking a leap in innovative cancer care. With more data comes more opportunity. Our digital and AI solutions enable clinical professionals to work more efficiently so they have more time for their patients. And digital twins have the potential to transform the healthcare of tomorrow, paving the way for personalized and preventive medicine. People are at the center of everything we do. We are a team of 66,000 at Siemens Healthineers, passionately pushing the boundaries of what is possible, proudly serving our customers by constantly bringing breakthrough innovations to market, enabling healthcare professionals to deliver high-quality care and ultimately improving patient outcomes and lives. The most advanced technology is only as good as the number of people who have access to it. As innovation leaders, we are committed to delivering scalable solutions that can be tailored to the needs of healthcare providers and local infrastructures across the world. We are pioneering breakthroughs in healthcare for everyone, everywhere.